Welcome everyone to Weber Training. I am Jim Goche, your host today for a presentation that I've been looking forward to. It gives me great pleasure to introduce Dr. Sally Bloomfield. She's currently chairperson of the International Scientific Forum on Home Hygiene. That group is working to raise awareness of the importance of hygiene in home and everyday life settings and developing and promoting hygiene practices based on scientific principles. This includes developing an understanding of hygiene issues such as the hygiene hypothesis and antimicrobial resistance. Sally was an honorary professor at London School of Hygiene and Tropical Medicine, and she was the senior lecturer at King's College London. She is also an honorary fellow of the Royal Society for Public Health. She has published over 120 papers on infection prevention, hygiene, and antimicrobial agents. Dr. Bloomfield's title today is How Do Perceptions of Hygiene and Cleanliness Influence Infection Prevention Behaviors in Our Homes and Everyday Lives and in Healthcare Settings? Dr. Bloomfield.
Hello, thank you, Jim, for that introduction, and thank you, Paul, for yet again inviting me to give another teleclass. I can't remember if it's my third or my fourth, but anyway, it's good to be back again. I think I ought to just start by explaining to those of you who are not familiar with what we do, who we are, the International Scientific Forum on Home Hygiene. We were established in 1997 as a not-for-profit, non-commercial, non-government organization. And the primary objective was to meet an unmet need, which was developing and promoting hygiene in home and everyday life settings based on the ever-growing scientific evidence that was becoming available at that time. Our target audience is government agencies, scientists, opinion formers, and so on. IFH doesn't work to communicate directly with the public. Our aim is to support those who do. And if you're interested and need information, over the years, we've accumulated a huge database of reviews and guidelines and so forth, which hopefully might help to support your work. One of the things we've been focusing on in the last 3 or 4 years is public understanding of hygiene, because we think we really do have to learn more. And the recent polling we've done right over the time from 2018 to 2024, both in UK and Europe, shows that although the public are concerned about hygiene, they're at the moment very confused about what hygiene is and how it differs from cleanliness. And this, I think, is having a very negative impact on their ability to practice effective hygiene. In this presentation, I'm going to focus on public hygiene behaviour in homes and everyday life in public spaces. But according to what you do yourselves, I invite you to consider, first of all, the implication of our approach for the hand and environmental hygiene in other public spaces and in healthcare settings, and also how the misperceptions about hygiene, which are acquired in the home, may probably impact negatively on how cleaning and healthcare professionals interpret hospital and other guidelines. IFH, since 1997, IFH has been developing an approach to hygiene, which is called targeted hygiene. It's based on well-accepted principles of risk management, which in scientific terms means focusing practices at the times, what we call the key moments, and the places, what we call the critical control points, to break the chain of infection. Put simply, for the public, it's about halting the journey of the germ to reduce exposure and infection risk, rather than eliminating microbial hazard, which is the way the public do tend to see hygiene. In 2020, we started to talk about how we could best explain targeted hygiene to the public. And this caused us to produce this practical guide, which you can download from our website. And I'm going to take some slides from that guide to just explain what we mean by targeted hygiene. Targeted hygiene starts from the concept that the main sources of infection in our homes are not places that are dirty. It's people, it's contaminated food, and it's domestic animals. And the other thing that people tend not to appreciate is that these infectious microbes don't move on their own. During our daily lives, we perform actions that cause harmful microbes to be spread from these sources in a way that we become exposed to them through our mouth, nose, and so on. Targeted hygiene is about acting at these moments to prevent the spread of infection. And there is a bottom line here. If we're not exposed to harmful microbes, we cannot be infected. So how did we set about the risk assessment? It's really quite straightforward. There are three stages. First of all, we started by assessing how people behave, the actions they take throughout their daily life at home, which may affect whether they become infected. We then assess the transmission routes of hygiene-related infections using the microbiological data on sources, transfer, exposure rates, dose, and so on. And from those, we are able to identify what are the risk moments which move microbes through the journey of the germ. By tabulating and comparing risk moments for spread of different infections, respiratory tract, gastrointestinal, infectious intestinal, skin, and so forth, it showed very easy, which you might expect, that many are common to several types of infection. And by narrowing this down, what we found was that we could identify 9 key moments which actually account for the majority of infection incidents in home settings. And if we take these 9 moments and impose them on our journey of the germ, we find that it looks something like this, in that we've got 5 that are the primary moments for moving germs from the 3 sources, and then the secondary key moments, like touching surfaces touched by others, handling food, laundry, and so forth. These and this diagram shows how they work and interact with each other to move harmful microbes from the primary sources to an infected person. These are not the only moments, but visualizing hygiene moments in this way does allow us to prompt about when to act and how to behave. Having looked at when to act, the next thing that we did was to produce a series of sheets, one for each key moment. And for each of them, we presented a graphic. This is the one for after handling raw foods, which illustrates what are the critical control points. From that, we can produce a checklist. And from that, we can give information for each critical control point about how to set about decontamination. And we like this because this is looking at it the way the public see it. First of all, they need to know when to act, then where to act, and then finally how to act. But the other key issue is that one of the cornerstones of targeted hygiene is that although hand hygiene is central to the key moments, it must be combined with the other practices, the other critical control practices, to maximize risk reduction. The model that we used to explain this, which we found very useful during the COVID pandemic, is called the Swiss cheese model. And I can illustrate that just by reference to what happened during COVID: coughing, sneezing, shouting, singing, and so forth. What the Swiss cheese model says is that each of these slices of cheese represents a barrier to infection. So we can see that it's about social distancing, it's about masks and so on, and about washing hands. It shows that none of these single actions is 100% infection. The Swiss cheese model shows how these barriers work together to reduce the overall risk of infection. So that's the general basis of targeted hygiene, but we then had to think, how do we set about communicating targeted hygiene to the public? And what we realized is that targeted hygiene is a story, and that storytelling is an accepted approach for getting behavior change. So in 2024, we carried out a trial in collaboration with the UK behavioural insight teams. And what we did was to develop a short video. We started with a long one, a 12-minute one, which you can have a look at, but we had to narrow it down to a 7-minute video for the trial, which used people and animations and so on to tell the story of targeted hygiene and how it halts the journey of the germ. We then went on to conduct a desk-based intervention to quantify whether targeted hygiene, communicated in this way, develops intention to behave in an effective way to break the journey of the germ. So here's the study. We had a sample of 2,500 adults randomized to see one of two videos, either the control video or the intervention group. They only saw it once, and the viewing time was only 7 minutes. We then asked them questions about, first of all, hygiene comprehension, the journey of the germ and targeted hygiene, what did they understand? And then secondly, their behavioral intentions in real life risk scenarios. Participants were given answer options and asked to identify one or more options that fitted their understanding of hygiene. So, first of all, the impact of the intervention on hygiene comprehension. And I think it's easier if I give you the heads up on what we found, because then the tables will be easier to decipher. So, the first stage, we found viewing the targeted hygiene video significantly increased comprehension of how harmful microbes spread and how targeted practices reduce the spread of infection. So I've tried to pare this down to a minimum just to give you an idea of what we saw. There are 4 questions that I've taken out. And the first 2 about whether they understood the journey of the germ and to what extent they did. So we had 2 groups, the control group and the prevention group. And question 1 was about how the most common harmful germs, infections introduced into the home. But they were asked to select 3 answers. You can see that what we've done is to divide the answers. They were given some that were correct in green and others which we considered incorrect or inappropriate. And what you can see immediately is that they were fairly good at identifying the correct common sources of harmful microbes. But in all cases, the intervention group scored higher than the control group. But what you can see is that they were also, both groups were quite keen to select indoor and outdoor spaces, dirty floors, surfaces and shoes as quite common sources of harmful microbes. Although, again, in this case, the intervention group scored lower. The second question was about how are harmful germs most commonly spread in the home, and they were asked to select 6 answers. And you can see that both groups, although again the intervention group scored higher, were fairly familiar with the common routes of spread. When we cough and sneeze, when we handle raw food, when we eat with our fingers, touch surfaces other people's touch, when we use the toilet, when we handle and stroke our pets, although that was somewhat less for the control group. But again, there was a very high number of the control group who said when they breathe on dirty surfaces and spread, that was reduced in the intervention group, but it was still 60%. The second group of questions were about understanding the chain, the concept of targeted hygiene. And here we asked 2 questions, and we asked them 2 questions for each. We gave them 1 choice only. And they were all about when should you practice hygiene to reduce the spread of harmful germs? At key moments and times when there's risk of harmful germs spreading was the answer we were looking for. Some of them selected that, and it was higher in the intervention group, but still, this idea was often as you can wash your hands frequently was often selected by both groups, although less in the intervention group. The same thing, what is the best way to reduce harmful germs spreading in your home? Okay, some of them said recognizing and acting at key moments, but quite a lot of them were still talking about keeping our homes clean and washing our hands frequently. But again, this was higher in the control group than the intervention group. The second group of questions were about the impact of the intervention on behavioral intentions in risk situations. And what we had found here was quite curious, because when questioned about their behavioral intention in real life scenarios, both the control group and the intervention group showed a high level of intention to act at the correct moments. Sadly, there was no significant difference between the responses of the two groups. However, what the quantitative trial failed to indicate was that both groups were equally likely to express intention to perform additional hygiene habits in situations where they would have had little impact. So let's see what that looks like. So we had the scenario we asked them about was either a gastrointestinal scenario or a respiratory tract infection scenario. So we divided it into two groups, and for each we had a control and an intervention group. So the question we asked was, when a family member has an infection, how likely are you to do the following in addition to hand washing? And so the answers we got really were very interesting, because what you can see is that they were quite good. They were pretty good at selecting the correct answers. But when it comes to some of them, there was a rather odd response. So, for example, with the gastrointestinal infection, although 90 to 93% said they would disinfect the toilet after use by a sick person, nearly the same percentage also said they would do that in the case of a respiratory tract infection, where it would have had little impact. And again, the other way around, 80%, 89% said that they would open windows and ventilate the home in the case of an respiratory infection. For obvious reasons, only 40% odd said they would wear masks, but an equal number of people said the same thing in terms of preventing a gastrointestinal infection. And you can see that for both of them, for both groups, they were keen to say that they would be likely to try and deep clean their home in this situation. So, but I think what's interesting that in addition to the trial, we learned quite a lot more about perceptions about cleanliness. And I've just taken these out from the earlier slides just to see what it looks like. And what you can see is that a significant proportion of both the control group and the intervention group selected these as one of their options. They were still very concerned about the importance of untargeted home cleanliness. However, the results do suggest that the video impacted to dispel these misconceptions in the intervention group. The question that probably concerns me most is the question, a common way that harmful germs spread in the home is when they breed on dirty surface and spread. And I find that very concerning. 72% in the control group, and although it was reduced in the intervention group, it was still 60%. Because if that's what they believe, it's going to be very difficult without dispelling that belief to be able to get them to practice effective targeted hygiene. So I've thrown quite a lot of information to you there in the form of tables and so forth. I thought at this point it would be worth just to summarize what we saw from the trial. What did we find from the trial, and what are the implications? When we look at hygiene comprehension, what we found was the intervention increased targeted hygiene comprehension within the intervention group, and that was significant. However, what we didn't quite expect was that both the groups could identify the key moments for hygiene. They knew what they were. However, when we went on to look at their behavioral intentions, intervention did not increase the intention of the intervention group to practice targeted hygiene in real life scenarios. Both groups were equally likely to express intention to perform additional hygiene habits, which would have little impact. So what have we got here? Well, the implications are that we've got a disconnect. We've got a disconnect between knowing key hygiene moments and applying them in practice. Since the results for both groups were so similar, it would tend to suggest that both groups were relying on pre-learned knowledge of key hygiene moments rather than applying reasoned behavior. The other finding as we've already said, is this misunderstanding of hygiene and cleanliness. We saw what a strong tendency there was in both groups to believe that germs breed and spread and that cleanliness is needed for extra hygiene benefit. However, what we found was that interventions could reduce these misperceptions. So the implications for that is if we can increase comprehension, we could overcome this barrier to effective hygiene behaviour. I've concentrated in this presentation so far on the most recent of our studies, but this is not the only time we've seen this disconnected. So I just wanted to share this one with you, which was a poll we did during COVID, asking people what are the important moments to wash and sanitize their hands. And at different points in the poll, we first of all asked them what would they do to prevent the spread of any type of infection, and then later on, what would they do specifically to prevent COVID. And what you can see is the results are very, very similar for the two questions. But what you find is that similarity means that to prevent COVID and spread of COVID infection, a significant proportion are saying I should be washing my hands after handling meat and poultry, after using the toilet, and after touching the pets. So that's the trial that we carried out, and the results that we got. But before moving on, I think I want to talk a little bit about this issue, which has come to the fore since COVID, which is the need to build hygiene resilience. During the pandemic, health agencies knew very well that public hygiene behaviour was key to mitigating spread, but that the public were ill prepared for this role. So during and since the pandemic, in response to it, government health agencies, both national agencies and international agencies, including WHO, have pledged to build health resilience, which includes hygiene resilience, i.e. the ability at home, in the workplace and elsewhere to adapt our behaviours as necessary to meet any future challenges. Epidemics, pandemic preparedness, tackling AMR, health inequalities, protecting health services, all of these are big issues and will remain so for the foreseeable future. When we think about it, what we realised that building hygiene resilience is doable if it is based on risk management. The other thing we realised too is that it has to be a two-stage process. So just looking at the two stages, the first one we've already talked about, which is about establishing targeted hygiene as part of routine daily life. This idea that there are key moments in our lives which are the highest risk for spreading harmful germs, and the need to act at these points to break the journey of the germ. This is the foundation, this idea of targeted hygiene for stage 2. And the important thing is that stage 2 depends on stage 1 being in place. So we can't just move straight to stage 2. We have got to work to build this basic framework. Stage 2, obviously, once stage 1 is in place, enables us to enhance, to adapt the framework to other settings such as schools and office and hospitalities, to enhance the framework in outbreaks or whether there are seasonal issues, for pandemic preparedness, to enhance input for vulnerable groups at home who are at increased risk of infection, and so on. And I've just included a couple of examples here. In 2024 in the UK, we had high seasonal levels of norovirus and cold and flu. So what we did then was to lift out the journey of the germ for each of those two situations, and then combine that with advice on where to act and how to act in order to enable people to enhance their hygiene behaviour against these two organisms or groups of organisms. I think building a resilient multi-barrier approach is important. It's not only just to enable advice to be intensified and relaxed to meet ongoing challenges, But the other important thing that it does is that it allows health agencies to weigh benefits of advising or mandating enhanced measures against disrupting social work and educational activities and later relaxing them. This became so important during the pandemic, through the years of the pandemic. And for this, building this resilience is vital for sustaining public engagement, confidence and trust in the face of constant policy changes. During the pandemic, this was a real problem because poor comprehension of the idea that ventilation and filtration and masking and social distancing and so on work together to maximum risk reduction had a real negative impact. And this was exacerbated by what we saw in the UK as very inappropriate messaging based on individual pieces of clinical data, which encourage the public to prioritize some actions and abandon others rather than sustaining a multi-barrier approach. For example, we saw messaging like clinical evidence for mask wearing is not very strong in either direction. That came directly from hospital studies. We need to double down on hand washing. Everything else is irrelevant. Why I'm cutting back on hand washing but keeping my mask on. And this was as various pieces of data were published in the literatures. And all this combined, I think, to make the public in the UK very confused and very distrustful of what government are saying. And it's something we have to find a way to overcome and to work on. Whilst I was writing this presentation, I came across this quote in Time magazine, which I thought I would include, about the appointment of Susan Manaras as the new lead for CDC. And what it said was, during the COVID pandemic, we saw the consequences of a too clinical mindset where decisions about mitigating spread outside healthcare settings were based on the same principles as those aimed at high-level projection of individual patients in healthcare based on RCT data. They reflected a framework centered on patients, not populations. Leading the CDC requires the opposite. It demands someone who understands the nuances of population data. And I think that's very telling. And I think it's something that we really must embrace if we are going to develop public hygiene resilience for the future. Since we have a global audience, I felt I should say something about developing global hygiene behavior, global hygiene behavior and hygiene resilience. Because what we've been thinking about is to what extent could a risk management approach be used globally for developing hygiene resilience? Because if you realize basic principles of spread of hygiene-related infections are the same globally, so it ought to be possible. What we know, of course, is that in low-income communities, the major focus has been and still is on hand washing to reduce diarrheal disease, and that has had a huge impact, for which the evidence has come through randomized controlled trials. I think that one could expand on this by having further separate interventions, but we believe that by adopting risk management, hand washing can then be combined, not separate interventions, but combined interventions, other practices as needed to address a global ID challenges. Obviously, one has to accept that in adapting targeted hygiene across high income to low income settings and within between countries and regions, there are going to be major differences across the spectrum which have to be addressed. It would be a major challenge. And just to give you two examples, I could cite several. In HMICs, obviously access to water and sanitation is not the key problem, whereas in LMICs, it is completely the opposite. It is the major problem. And so much of the resource is dedicated towards this. In HMICs, people have basic comprehension of germs and how they spread. The problem is that we have become confused by the widely publicized myths and misunderstandings. In low resource settings, on the other hand, people have limited understanding of how infections are caused in the first place, let alone how they are spread. So there's huge differences, but it should be possible to apply a risk management approach as needed to develop hygiene resilience. So for the rest of this presentation, what I'd like to do is to talk a little bit about the proposed policy that IFH is developing, has developed for developing effective public hygiene behaviour. And if you're interested in this, you can download a policy paper which we have uploaded onto the website, which sets out this policy. It's a three-component policy, and the first component is obviously developing risk-based approaches. It's about gaining acceptance that the risk management approach is a prerequisite and is the means by which we can develop not just effective, but obviously resilient hygiene behaviour, both in our homes and in everyday life in public spaces. The second thing we have to do is to gain recognition that it is already a well-accepted scientific-based approach, which is difficult amongst within an area of expertise, which is mainly dominated by people who are clinically trained. And people say to us when we talk about a targeted hygiene, this approach really makes sense. Yes, that sounds good, but where is your evidence base? I.e., where is your randomized control trial data? They are reluctant to consider whether a clinical approach is appropriate for tackling population risk. I don't think it's deliberate, you just don't know what you've not heard about. In the last 10 to 20 years, however, we've seen the development of something called quantitative microbial risk assessment. And this overcomes one of the key problems with a risk management approach because it enables us to use quantitative data to estimate the impact of interventions on infection rates, not just on the occurrence of microorganisms and then their transmission. And one of the things that IFH is doing now is to working with Kelly Reynolds and her group from the University of Arizona on the application of quantitative microbial risk assessment in home and everyday life hygiene. And what I've done is to just include this slide just to give you a feel of what quantitative microbial risk assessment might look like and what it might do. This is just an example of a study. It's back from 2005, but it's nice and simple. So I think it's relatively easy to understand. And I've tried to do it pictorial so that it gives you an idea. This was a study of the impact of hand hygiene on US population risk, 200 million people, of hand-to-mouth transmission of E. coli after handling contaminated beef. And what they did was to do the modeling, to take the scientific data, and if you look at the left-hand side y-axis, they determined the bioburden that is likely to be on a surface, on the hand surfaces following the handling of contaminated minced beef. The first situation, obviously, they looked at was no hand washing, and using mathematic modelling of the published data on sources and survival and rates of transfer, exposure, and infectious dose, what they were able to estimate, which is on the right-hand y-axis, is the population infection risk from that situation. They then went on to say, okay, if we were to wash our hands before touching our mouth following the handling of minced beef, then this would produce a 0.3 log reduction in the bioburden on hands. I think that's quite low. I think probably you can get a higher log reduction, but that was the data from the literature they chose to use. And you can see by doing the estimation of the infection risk, what they were saying was a 98% risk reduction. The third part of the study was to look at the effect of an alcohol hand rub, which the data suggests can produce up to 4.3 log reduction on hands, in which case this computed to a 99.996% risk reduction. So using this data, what this allows us to do then is to set and work to safety target levels which we think appropriate to the situation. And it opens up all sorts of probabilities of understanding the relative importance of different interventions at different critical points and so on. So obviously it's only as good as the data that we put into the models, but all the time that data is increasing. And I think it gives us a very powerful tool to be able to make rapid decisions about changes in hygiene policy, which could not be done if we are relying on randomized control trials. The second area that we're working on is this business of developing hygiene behavior change, because I think what we've decided from what we've seen from the trial is that by further developing strategies involving visualized storytelling, it should be possible to take learned hygiene habits and turn them into effective hygiene behavior. We think the journey of the germ story gives us a real advantage in being able to engage the public through visualizing hygiene practices rather than a list of actions that have to be memorized. And this gives us a real head start over other types of health policy strategies where people have to rely on data from trials and so forth and numbers and whatever. I think the idea of the journey of the germ gives us a real head start in terms of engaging and the public to practice targeted hygiene. Obviously, we need to carry out further work to do key things. First of all, to find out about the root cause of the disconnect between targeted hygiene comprehension and applying it to real life scenarios and how to overcome it. One of our concerns is that when you're giving people answer options, it may influence what they say. So we want to do some focus group work to try and mine out what exactly is going on. And the second thing is, how do we dispel these misperceptions about cleanliness, which are a barrier to effective behavior? I think I have to conclude that some of the blame for misleading, for the misunderstanding of hygiene comes from these constant media messages communicated through articles which have eroded public understanding. I've seen these published time and time again over the 30 years when I've been working in microbiology, and they always say the same sort of things. The bathroom is a haven for bacteria breeding in places you believe are sparkling clean, millions of germs. Here's a map to help you identify where germs love to lurk and help you banish the bugs. 200,000 organisms, think again, all about scaremongering about the germs that hide and lurk in your homes, but never saying that these millions of germs are not harmful and possibly are beneficial. I think these must have had a very significant impact in eroding public misunderstanding. But I think too, during the COVID pandemic, these media images of spraying and fogging rituals that public health departments believed made us safe must have had a significant impact, because if public health authorities are doing this, it means it must be correct. The third of the areas that we're working in is something which is called systems approach or systems thinking. And this is something that I think is being developed globally. It's attracting more and more attention. I can best explain it to you, I think, through an example. what COVID did was to highlight the importance of infection prevention in public spaces. The shutdowns and so forth made you realize the extent to which infection spread was occurring in public spaces, offices, schools, hospitality, public transport, and so on. But what this did when businesses were opening up was to result in a huge investment of time and resource in deep cleaning protocols for public spaces, in the belief that this would keep us safe. We come and come to our premises. You'll be all right with us. It's perfectly safe. We deep clean every night, and so it will be safe for you. But this completely missed the point, because keeping premises cleaning was only just part of the story. In essence, the major part of keeping safe is the behaviour of people who were visiting those spaces. And what it became realised was that preventing the spread of infection in public spaces has to be a shared partnership between the public and how they behave, and between the managers of these spaces, which means that these managers must not only adopt responsibility for keeping the place clean, but also for facilitating and encouraging effective behaviour whilst people are within these premises. So one of the things that IFH is doing now is working with the British Cleaning Council towards developing hygiene systems for public spaces. And I think this has very significant implications, not just for public spaces outside hospital settings, but also inside healthcare settings when it comes to environmental hygiene and cleanliness. If you're interested in a systems approach, you might like to have a look at a report which we've hosted on our website, which was of a large-scale intervention that was carried out during the COVID pandemic at the COP26 conference on climate change. And this intervention was led by a colleague of mine, Lisa Ackley, who is an IFH board member. And what she did was to put together a team which carried out a detailed risk assessment of the public spaces within the conference centre to identify the critical moments, the critical control points for hand and surface hygiene during the session. They then trained up a hygiene task force to deliver the intervention, ensuring disinfection of contact surfaces within and between and during sessions, but also encouraging and prompting effective hygiene behaviours by the delegates. The cleanliness of the venue was delivered by the cleaning contractors. And although obviously we have no control to prove it, it's interesting that the conference was delivered at a very sensitive time without a COVID outbreak, despite the fact that there was a very high levels of COVID in Glasgow at that time during December, and people were coming and going to service the venue, all and interacting with the delegates. But I think that's a very useful illustration in detail of how they set about doing the risk assessment and what they did. But I think it's got to the stage now that we really must think more carefully about this difference between cleaning and hygiene. It's something that we have to address. What we did, interestingly, during 2020 polling was a study across 25 European countries where we asked them what they thought was the difference between hygiene and cleaning. And it was very interesting that, considering that the countries were right the way across from Norway to the Mediterranean, from Ireland right across to Romania, enormous differences in culture, the limits within which the responses came back were really quite narrow. So what we found was that 55 to 68% fine said hygiene is more than cleaning, it's about protecting health. But as much as 15 to 20% said cleaning and hygiene are the same thing. If its surface is clean, it's also hygienic. And then 16 to 28%, which rather surprised us, said cleaning means using a cleaning product. hygiene means using a disinfectant. And if you think about that, that's going to have an enormous impact on how these groups of people interpret and act on hygiene. The advice that they're being given. And again, I will say, since cleaning professionals move between home and work lives, these misconceptions are very likely to impact on how they interpret cleaning and hygiene guidelines. So I think we have to recognize and be very open about the fact that environmental hygiene and cleanliness in public and healthcare settings has two fundamentally different functions. Firstly, hygiene, aimed at reducing the risk of exposure to pathogenic microbes. And it's about reducing contamination of hands and surfaces to an acceptable, safe level using a prescribed decontamination procedure. Is it important? Yes. But equally, visual cleanliness means the absence of visual dirt. It is something very different because it is just simply the physical removal of dust and soil and so forth until the surface is visibly clean. Is it important? Yes, it's equally important because whatever we say, it is the means by which people and staff judge whether clean, safe food or safe care is being delivered, or the other way around, that if it's not clean and if it doesn't appear to be clean, it's unlikely that the care or the food that is being delivered is going to be safe. I came across this quote, which I think summed it up for me, a professional institutional cleaning expert who said, if someone asks me to clean that surface, I don't know what to do unless I know what the surface will be used for. And I think that's very true. And in the last few months, I have done quite a lot of work examining guidelines for hospitals and public spaces, and seeing that they really do lack clarity on what is achieved if guidelines are followed. Are they aiming at infection prevention, or is it aiming at cleanliness, or is it both? It's never discussed and it's never explained. And I don't know why that is, because it is so important. So I think I've come to the final parts. First of all, just trying to sum up what I think is the impact of our work. I hope what I've shown is that people are aware that key hygiene practices, hand surfaces and so forth. The problem is that they lack comprehension of when and where to apply them. I think what we're finding is that prescriptive guidance is not enough, that needs memorizing. What we need to do is to build practical knowledge of how hygiene halts the journey of the germ. It's also become obvious that if we are going to get behavior change, we have to work proactively to dispel these myths and misunderstandings that are currently acting as a barrier to change. I think also we need to recognize that this lack of clear understanding of hygiene and how it differs from cleanliness has wider implications, that trained professionals are likely to have ingrained habits and beliefs developed during formative years, which are acting as a barrier to effective environmental hygiene behavior in the workplace. And then finally, I think that our work suggests that if we're going to develop resilient hygiene behavior that is sufficient to meet 21st century needs, it needs to involve adopting a risk management approach alongside clinical approach if we're going to achieve this. So just finally, a few thoughts that I've had about where we go from here. Because if hygiene in home and everyday life is such a vital part of infection prevention, why is it so underinvested? I don't think it's deliberate. I think there is a finite resource available worldwide, which is inevitably being devoted to firefighting in healthcare settings, and which is leaving limited resources to fighting issues that fuel this fire, even though I feel that we must be fully aware that these issues do fuel the fire, and that if we could also tackle this issue, we are also at the same time tackling the healthcare settings issue. I think, and I'll repeat it again, that some of the problem is reluctance to consider risk management as appropriate to tackling population risk. And I think as long as this continues, we will see more of the same. During the pandemic, and even now, if the issue of hygiene in homes and everyday lives is raised and questions are asked in parliamentary hearings and so forth, the knee-jerk response is, oh, well, we need to make sure that people wash their hands frequently. And that's the kind of mantra that is used, and it's just not right. We need something much more helpful to the public than just wash your hands frequently. The other thing is that the lack of leadership. At the present, if you look at hygiene in home and everyday life, it's mostly dealt as a side issue of other issues. So, for example, healthcare at home is a side issue of healthcare in hospitals. Pandemic preparedness is a side issue. Home and everyday life is a side issue of dealing with pandemics in hospitals. Food hygiene, our Food Standards Agency deals with food hygiene at home as a side issue of the farm to fork thing. What we need is the need for leadership with sole responsibility for home and everyday life hygiene, the power to drive change and to look at it from the point of view of the public and how they see it, not how agencies see it. Advocating for action against competing health issues, and also recognizing the complementarities and the differences between everyday life and healthcare hygiene. So I hope I've persuaded you perhaps that risk management offers a way to build hygiene behavior and resilience to meet future needs. But also that it's doable without massive investment, because what we need to do is not to go back and start from scratch. We can build on existing knowledge of key hygiene and practices. It's not rocket science. So thank you very much for listening. I hope I've said something that you found interesting or useful. And thank you very much for inviting me again, Paul.
Well, thank you very much for this presentation. I've been sitting here wildly making notes as you've gone through this. And the first thing that came, and I mentioned this to you before we actually came online, is I loved teaching young children how to properly wash their hands. And it was just a simple technique of using the fluorescent gel that you have the children put on their hands, send them off to use some soap and water, turn out the lights, and use a black light to show them what they missed. So I did this when we moved to Ontario. I did my daughter's grade 1 class and my son's grade 3 class. I went back to do the grade 5 class of my son and noticed the young girls tended to wash their hands much better the second time through that I did this than the boys who just wanted to play with the gel. But they were young enough that I could talk to them about the importance of hand hygiene and when to do it. And then sure enough, down the road, when one of the girls was about 14 or 15, she came to my hospital to volunteer. And I did in the hospital setting, everyone puts on a pair of gloves. I had some red finger paint to their hands, asked them to show me how they use that as soap so that I can see how they distribute it over their glove after telling them not to wash their gloves. But this girl that had been taught in grade 3 and 5 perfectly covered her gloves with the red paint. She did a perfect hand wash. And sure enough, 4 or 5 years later, she comes through as a nursing student through my setting, and again has to do this hand hygiene. And I watched again that she did a perfect hand hygiene because we had taught her at the age of roughly 8 years of age how to wash her hands properly. So do you see this hygiene concept being taught to the younger children to understand the risks of life in general?
Yeah, yes, and in Europe we've got this thing called e-bug, which is something which was instigated by the EU to make sure every child leaves school with an understanding of antibiotic resistance was the thrust, but hygiene, the basic principles of hygiene. But I think that e-bug is doing the heavy lifting in that it's teaching children how to wash their hands and so on. But for me, it's about getting this consciousness of what we're doing, that when we wash our hands, we're not just getting rid of germs from our hands, we are stopping them from moving. And the only thing that I find the best sort of way of describing is a little bit like the car seat belt, in that when we get into the car, we put the belt on, we know that it's a law, but at the same time, we all also have this subconscious thing in our mind, this subconscious visualization of the journey of our forehead into the windscreen if we have an accident. And that's what we need to inculcate in people. Not that they are all the time thinking and worrying, but when they see a chicken, or when they've been to the toilet, they don't just have this vision, I've got to get rid of germs. They have a vision of I am trying to stop the movement of the germs. I think we've got so obsessed with this vision of getting rid of them, where in fact, what we're trying to do is to stop them from moving. Would be my response.
Yep. And within your program of the 9 key moments with the targeted hygiene, do you discuss the portal of entry? Because to me, having people understand that I don't care what's on your hand, if it can't get into your eye, your nose, your mouth, hopefully not up your rectum, but if it can't get to a portal of entry, you're not going to get sick. And before you get it to the portal of entry, wash your hands before you eat and put something in your mouth. If you've got an eyelash in your eye, I used to wear contact lenses, and I would wash my hands very diligently before I removed a contact lens to take an eyelash out, recognizing that it's a portal of entry. Is that part of the program?
Yeah, yes, and yes, and because that, I don't even notice, that was the journey of the germ. And I think it was very interesting when we did our polling in 2020, when we asked people how they thought they got infected, they said by breathing in and this, that. A high percentage did say, if I touch my mouth, nose and eyes with contaminated hands. That was a high percentage of people. So it showed they did recognize it. The thing that was fascinating, though, was we gave the option that one of the ways I get infected is because COVID gets through the skin of my hands.
Right.
And we thought, what's going on here? And obviously, because they were being told to wash their hands frequently, but had no visual image of what they were trying to do, they assumed it was because they were going to get infected through the skin of their hands. And that was 20% to 30% of people. And that we found that quite shocking, which is why people wanted to wear gloves during COVID, because it protected their hands. So you can see that this business of building comprehension of the journey of the germ and building practical knowledge within that comprehension, I think is quite key. And because it's visual and because it's a story, I think we can do it.
I'm hoping it just makes perfect sense. One of the things that I wrote down while you were talking on one of your slides is you're running up against our advertisers on TV, where everything has to be sanitized. There's a commercial where mom's coming home from the airport and dad's spraying down her suitcase first thing. And I'm thinking, okay, what's the chain of transmission here from the suitcase? Yes, mom should wash her hands because she's been in an airplane and a taxi and she's finally home. And she's probably going to have something to eat or drink with the kids in the house. But why are we spraying the suitcase? So do you see that in Great Britain? Do you get these kind of home sanitizing messages coming out on everything?
Yes, I think a number of the household care manufacturers who have a strong scientific base are now really working towards their products being products that aid targeted hygiene. But I think there is always the entrepreneurs. I mean, the worst one during COVID was this guy who was going to develop booths that you could put around football grounds, and everyone walked through these booths and they were sanitized, and then it would be safe for them to be in the football ground. And that's just horrific. And unfortunately, of course, it will always happen. How we stop that, I don't know. I wish I did know. because unfortunately it sells newsprint and it sells products. No, do you have any suggestions as to how we work to displace that?
Yeah, and it's again, that's where this program of targeted hygiene helps understand that you don't need this. And I think you had a slide about what do we actually need. I always lectured that a good clean, wiping a surface with a wet cloth, I don't care what's on it, is a 2-log reduction. You're going to remove 99% of the microorganisms that may be present on a surface. And then when you get into sanitizing, you're at 3-log, unless it's a food contact surface, but I won't go down there. And then when you disinfect, it's a 6-log reduction. And then you start looking at what is truly on a surface, a visibly clean surface. How many microorganisms are truly present? And in many cases in the home, cleaning is going to be more than adequate. You don't have to start adding chemicals. And even in the healthcare setting, I think sanitizing surfaces is probably more than adequate, especially when we talk about floors, where many hospital settings, as you're probably aware, want to disinfect floors. And it's breaking down the floors, it's hurting the people with the chemicals that we're using. So I think we also, like you said, we need a much better understanding of what's on surface in terms of quantitation and what do we actually have to do within the healthcare setting.
Yeah, I think this is where QMRA is going to help us, because what you suddenly realize that it takes into account infectious dose. And for something like norovirus, the infectious dose is very small. So if you are coping, whereas you might say, okay, cleaning of surfaces with by wiping is enough in this, and this situation. If you've got a norovirus outbreak, that's when you need to the added log reduction of a disinfectant. So I'm hoping that and that's what Kelly Reynolds is working towards, is to better understand what is effective hygiene and how we develop this. Because I mean, what's 5-log reduction? All our products have to meet 5-log reduction. Where does that come from? Well, it's because when we were setting up the tests, you could get 10 to the 8 in a test tube, and the limits of error meant you could measure a 5-log reduction. And all the disinfectants we had in the 1900s could meet this standard. So any new disinfectant must be at least as good as that. There was no clinical thinking, and we're now stuck with this. But hopefully QMRA will help us to make hygiene procedures more sustainable in terms of the resources. I mean, they're all about using water or heat or biocides or removal as the resources. It's using them in combination in the most sustainable way to reduce risk to an acceptable level.
And yeah, I think we need much more research. When I put a presentation on together on what to do with floors, whether you need to clean, sanitize, or disinfect, it's amazing how little literature is out there as to the microbial burden on a floor. Yeah. Visibly soiled, totally different. We all know what's present in saliva. We know what's present in feces. But in terms of a visibly clean floor, especially around organisms like Clostridioides difficile, where everyone goes crazy with it, and you look at some of the papers where they have done some culturing, there's really not a lot of spores out there in our environment. So I think, yeah, we need a lot of work around that. I think we need to calm down a lot of people what they are doing at home for sure. And we even did a paper back in 2020 called Targeted Moments of Environmental Disinfection for Healthcare, where we tried to base 5 moments on the care practices that probably leave microorganisms in the environment, and tried to mimic the 5 moments of hand hygiene. And it sort of echoed when you were talking about the 9 key moments for your program, that we're just trying to say you don't need to clean all the time or disinfect all the time, but there are certain times that we really need to have to do it.
Yeah.
Okay. We're at the end of our time here, Dr. Bloomfield. Thank you very much for the presentation that you gave us.
Thank you.
I just need to click on my slide up here. We can see here, these are the upcoming Weber training presentations that we've got. I'm not going to go through all of them here, but I can see Paul Weber has set up quite the list of things coming up. We've got some live presentations that will be coming from the IPS conference later in September. I'd also like to thank our patron sponsors, Diversi, which is a Solenis company, Virox Technologies, and Gamma Healthcare, who support these teleclass education sessions. Again, Dr. Bloomfield, thank you very much for your presentation today, and I'm looking forward to talking to you down the road. Thanks, everyone.
I shall enjoy that. Thank you.